This 10-minute presentation is a review of the recent evidence to use injectable orthobiologics for biologic augmentation of rotator cuff repair. Our clinic can be found at orthobiotexas.com. These are my disclosures, and they are available on the American Academy of Orthopedic Surgeons website. This is a QR code that will take you to the handout. The handout can also be located at buford.info/webinar handout. So a brief review of the evidence. The Food and Drug Administration in the United States has repetitively ruled that injectable allograft birth tissue products are all drugs in the orthopedic market. None of these injectable allograft products have a current FDA-approved indication, meaning that we have no on-label indication for any of these products. So unless we are investigators in an FDA-registered study, known as an IND, we cannot use these products. Examples of such products include Wharton's jelly, exosomes, amniotic fluid, and even some products identified as proteins that are actually allograft in nature and considered drugs by the FDA. I do not work for the FDA and I'm not an attorney, so I always advise the clinician to do their own research and be highly suspicious of a company that only gives you their opinion or their attorney's opinion and not an actual opinion from the FDA itself. For the purposes of this review, I'm going to focus on human outcome studies using FDA regulatory compliant orthobiologics as of April 2024. The three that we will focus on are platelet-rich plasma, or PRP, bone marrow concentrate, and a particular form of adipose known as microfat, because that is currently regulatory compliant when it is created with a 510(k) cleared device in the United States. So let's start with platelet-rich plasma. In 2023, we had a summary paper that was also a systematic review of 20 separate level 1 studies looking at PRP augmentation of rotator cuff repair. Their conclusion was that the use of PRP as augmentation in rotator cuff repair significantly reduces the re-tear rate. In my opinion, this conclusion is really significant because not all of the PRP used in these 20 level 1 studies was the same. And this meta-analysis included some PRP that was relatively low dose in the studies where the dose was quantified. Nonetheless, when all of these papers were pooled and the results analyzed, it was clear that PRP is a significantly beneficial biologic augmentation, with the main goal being to reduce the re-tear rate. Here is an example of a dose response curve for platelet-rich plasma. At the current time, we have evidence in the literature supporting that a platelet dose of 5 billion in a single injection gives us a much better response compared to a dose that is at 2 billion or even 2.5 billion platelets. Current research is geared towards increasing the dose above 5 billion in a single injection or at the time of surgery to see if we can get even better clinical outcomes. So how do we get to 5 billion platelets? Well, first is to understand how we calculate the dose. Platelet dose is injected volume of PRP times the platelet concentration in the PRP. So if you don't have a hematology machine to analyze the blood and the PRP, you won't be able to calculate a platelet dose. The best we can do is estimate based on the platelet or PRP kit that you're using. However, if we want to safely get to 5 billion platelets every time, even without the ability to test every dose, these are the 5 steps that I would recommend that you do. Number 1, assume that the lowest normal human platelet count is 150, and that's where you're starting. Draw 54 to 60 cc's of blood in a 60 cc syringe. If you draw less than 60 cc's of blood, the balance would be made up of your anticoagulant. If you do that, your starting platelet dose will be somewhere between 8 and 9 billion platelets. And again, we're assuming that our patient, who we can't test, has the lowest normal human platelet count. At that point, if we know our kit's platelet recovery percentage, and that recovery percentage is 60% or better, then we should be able to comfortably estimate that we are giving a dose of 5 billion platelets or more. Of course, if our patient has a platelet count that is higher than the lowest normal platelet count, say our patient's platelet count is 300, then we're even in a better situation and our platelet dose will be even higher, of course. The pro tip here is if you have a kit with a recovery percentage less than 60%, you should draw 2 times the blood, which would be 120 cc's of blood, in order to make sure you're getting to a platelet dose of 5 billion, if that is your target. Let's look at bone marrow concentrate. This study was released in 2022, and what it showed was that the bone marrow aspirate concentrate patients had 64% fewer revisions at 2 years compared to PRP patients. The patients that had PRP augmentation during their rotator cuff repair showed no difference in revisions. So this was strong evidence supporting the use of bone marrow aspirate concentrate as the best biologic to minimize rotator cuff revision surgery. Here's another study looking at bone marrow concentrate augmentation of rotator cuff, where the lead author was Dr. Brian Cole. This was just published last year in 2023. This was a level 1 clinical trial with about 45 patients in each group. They had 2 years follow-up. They used the Arthrex Angel system and drew 60 cc's of iliac crest bone marrow. They did quantify the MSC dose and found that to be 25,000 in a volume of 2.7 cc's. And the results were encouraging. The bone marrow aspirate concentrate group showed improved tendon quality by MRI scan at 1 year. In addition, just like the prior study, the bone marrow aspirate concentrate group had fewer retears on MRI scan at 1 year. So this is another study suggesting that bone marrow aspirate concentrate can be a useful biologic adjunct for rotator cuff repair. This is still the landmark study looking at bone marrow aspirate concentrate for rotator cuff repair augmentation. This was published by Philippe Hernigau in 2014. This was published in International Orthopedics. He had 2 groups, a control group and a treatment group with 45 patients in each group. Notice that he drew significantly more bone marrow than the prior study. The prior study drew 60 cc's, and in Dr. Hernigau's study, he drew 150 cc's of bone marrow. His dose was higher at 51,000 MSCs and 12 cc's of bone marrow aspirate concentrate. And then finally, the critical thing to recognize here is his technique, his protocol. 2/3 of the injectate was put back into the greater tuberosity. So you can see here 8 cc's was injected into the bone. The remaining 4 cc's was injected at the tendon bone interface. So here we have a protocol, a nicely quantified study, and we can look at the results were really astounding even 10 years ago. 100% of the patients, so all 45 patients had healed rotator cuff tears at 6 months by MRI scan. And furthermore, 10 years later, 87% of the patients still had intact rotator cuff repairs by MRI scan. When you compare that to controls, it was clear that the intervention, the bone marrow aspirate concentrate, made a statistically significant impact on these patients in terms of healing and long-term durability of the repair. What about adipose augmentation? Well, there's not much in the literature yet to support microfat or even nanofat augmentation of rotator cuff repair. Here's the most recent, and I think the best study so far in a peer-reviewed journal, published in 2022. Lead author is Pietro Randelli. 22 patients had microfat treatment using the Lipogems technique, and 22 patients were in the control group. In this technique, the Lipogems product was injected into the subacromial space. And what they found was that the microfat treated group was better than control on the constant score at 6 months only. At every other time point, the groups were identical in every metric that was evaluated. So there really wasn't much difference or much benefit to adding Lipogems to a rotator cuff repair in this study. There were no differences in failure rate, complications, or adverse events. So where does that leave us now in 2024? Right now, I do think we can help improve rotator cuff repair outcomes with biologic augmentation, but the dose and the how of augmenting is clearly important. The current best evidence in the literature is showing that bone marrow concentrate is giving us a better outcome than platelet-rich plasma, which is giving us a better outcome than adipose, for which we just don't really have enough clinical data yet. So thank you for your attention. These are all the different ways we can be reached on social media, and thank you.